Carcinoma of the rectum. Colorectal carcinoma is the fourth most common variety of malignant tumor found in female and the second in the male. After carcinoma of the lung, risk factors, carcinoma of the rectum إذن هو الفورث malignant tumor in female and the second in male. In male after carcinoma of the lung. Risk factors for carcinoma of the rectum. First is advanced age, dietary factor like high animal fat, genetic factors, FAP, familial adenomatous polyposis, ulcerative colitis and Crohn's disease, that's to say inflammatory bowel disease, with colorectal involvements and family history of CA rectum and family history of carcinoma of the colon. These are risk factors for carcinoma of the rectum or colorectal carcinoma. And pathologically, three types of carcinoma, either well differentiated or averagely differentiated adenocarcinoma and anaplastic, highly undifferentiated, highly aggressive tumor adenocarcinoma of the rectum. And macroscopically, it is either ulcerative or papilliferous or infiltrative and annular. إذن بالمicroscopically إنه ممكن تكون ulcerative colorectal carcinoma or rectal carcinoma or papilliferous carcinoma or infiltrating in the walls or annular tumor, and sometimes cause, it is one of the causes, especially rectosigmoid tumor due to annular carcinoma causing intestinal obstruction. And spread of the carcinoma of the rectum, there is local spread. It occurs circumferentially rather than longitudinally, and period of 6 months is required for involvement of a quarter of the circumference. يعني ربع الwall involved in 6 months. In fact, it is a slowly growing tumor. And 18 to 24 months to complete encirclement. يعني نحتاج سنة ونص إلى سنتين for full involvement of the wall of the rectum. It is slowly growing tumor. If spread occur anteriorly in the male to the prostate, seminal vesicles, or the urinary bladder, this is in male, while in female, involvement of the vagina or uterus, invaded, especially cervix of the uterus, is involved in female, prostate in male. If spread laterally, may involve the ureters, if posterior involvement of the sacrum and sacral plexus. Lymphatic spread of the carcinoma of the rectum, enlargement of lymph node from bacterial infection more common than infiltration by malignant cells, but still there is involvement of the lymphatic drainage according to the corresponding blood vessels. Direction of lymphatic spread in the carcinoma of the rectum usually upward, except 1 to 2 centimeter orifice. If this is spread inferiorly to the in the direction of inguinal lymph node. If neoplasm lie within the field of middle rectal artery, that's to say 4 to 8 centimeter from the anus, spread goes laterally accompanying middle rectal vein. Growing lymph nodes may involve spread subcutaneously when there is involvement of distal 1 to 2 centimeters. And venous spread, it usually occurs lateral, except when the tumor is highly malignant and occur in young patients, spread occur early. Liver involvement in 34%, lung involvement 22%, and adrenal gland involvement 11%. Then common spread hepatic metastasis. And peritoneal dissemination may occur in highly lying rectal carcinoma. إحنا نعرف إنه the upper third of the rectum is intraperitoneal structure and can spread through the peritoneal cavity and one of the causes of malignant ascites. Regarding the staging of the carcinoma of the rectum, Duke's staging of colorectal carcinoma. Duke's stage A, Duke's يتقسم stage A, stage B, C, and Duke D. ورا ما توفى Duke صارت Duke D. Stage A, Duke A, the growth is limited to the rectal wall, 15%. This is 15%, and the prognosis is excellent. In stage A, the growth is limited to the rectal wall. This is only 15%. Prognosis is excellent. While stage B, the growth is extended to the extrarectal tissue, but no metastasis to the regional lymph node. This is 35%, and the prognosis is reasonable. Then stage B, growth extended to extrarectal tissue, but no metastasis to the regional lymph node. This is 35%, and prognosis is reasonable. Stage C, regional lymph node involved in 50%. It is divided into C1, local pararectal lymph node alone are involved, and C2, lymph node accompanying the supplying blood vessels are involved. إذن Duke C يتقسم C1 local pararectal lymph nodes, C2 لا هنا أبعد lymph node accompany the supplying blood vessels are involved. And the stage B, widespread metastasis, distant metastasis, and commonly into the liver. This is the Duke staging, while TNM classification, T tumor local spread T1, T2, T3, T4, nodal involvement, and nodal involvement, N1, N2, N3, and distal metastasis or distant metastasis, either M0 if it is no distal metastasis, or M1 if there is distant metastasis. And histological grading of carcinoma of the rectum, there is low grade, well differentiated, and the prognosis is very good. Good prognosis, 11%, or average grade. This is commonest, 64%, and the prognosis is fair, while high-grade tumor and plastic tumor, 25% with poor prognosis. Regarding the clinical features of the carcinoma of the rectum, the patient may present with the following. First, bleeding is the earliest and most common symptoms. Usually bleeding is slight and after defecation. Second, sense of incomplete defecation. It is very important, early symptoms, and it is almost invariably present in tumors of the lower half of the rectum. Third, alteration of bowel habits, usually early morning, bloody, diarrhea, أو يسموها early morning sleep. Fourth, pain, which is the late symptom, but colicky abdominal pain due to some degree of intestinal obstruction because of annular tumor of advanced growth or rectosigmoid area. Then, clinical features, bleeding is important, alteration in bowel habits, and sense of incomplete defecation and evacuation, and pain, which is late symptoms, and important thing is hemorrhoid, and any hemorrhoid after 45 years of age should be subjected for sigmoidoscopy or colonoscopy in order to exclude carcinoma of the rectum or colorectal carcinoma. Examination, abdominal palpation is negative in early cases, but careful attention must be paid to detection of hepatomegaly, ascites, and abdominal distension. This is due to dissemination of the tumor, especially of the upper third of the rectum. Other general feature that may be detected in late cases, large supraclavicular lymph nodes, node in the groin or jaundice due to involvement, hepatic metastasis and involvement of parahilar lymph node. And rectal examination reveals the tumor in 90% of the cases. Then, any patient with hemorrhoid of the age of 40 or 45, you have to do the rectal examination because 90% of rectal tumors can be felt with a rectal examination. And the special investigations for carcinoma of the rectum, we have to do proctoscopy, we have to do sigmoidoscopy, enables the great majority of the tumor to be inspected and biopsy to be taken. And colonoscopy is required, if possible, in all patients to exclude synchronous tumor. Colonoscopy, entire colon and distal small bowel, and flexible sigmoidoscopy, distal 60 centimeter. Rigid proctoscopy, distal 25 centimeter. احنا نعرف انه الريكتم هو 3 parts and the tumors of the lower and middle part and even of the upper third of the rectum can be felt by their digital examination. لذلك الريجيد proctoscopy can detect and can visualize the tumor, rectal tumor, also in flexible sigmoidoscopy. Barium enema is indicated when colonoscopy can't do it, or if the growth is not visualized sigmoidoscopically or colonoscopically, or if a second tumor is suspected. 5% of tumors in the large bowel are multiple, or if there is ulcerative colitis or familial polyposis. These cases you have to use barium enema, and ultrasound of the abdomen may detect liver metastasis and or ascites, while transrectal ultrasound to determine the depth of rectal wall invasion by small tumors and lymph node involvement. CT scan and MRI and sigmoidoscopy for detecting local recurrences. Differential diagnosis of the rectal tumor. Differential diagnosis of palpable tumor in the rectum must be made from the following: benign tumors like inflammatory structure, solitary rectal ulcer, and secondary deposits in the pelvis, ovarian or uterine tumors, extension from the carcinoma of the prostate or uterine cervix, and diverticular disease. Endometriosis also comes in differential diagnosis of rectal carcinoma. Lymphogranuloma inguinale and amoebic granuloma also comes in differential diagnosis of the carcinoma of the rectum. And feces, this gives the classical physical signs of indentation, especially in fecal impaction. There is dewy sensation. These give the classical physical signs of indentation. And treatment of the carcinoma of the rectum could be curative or maybe conservative for advanced and highly malignant tumors. The curative surgery depends upon the distance from the tumor, from the anal verge. Upper third tumors can be resected with restorative anastomosis between the sigmoid colon and the lower rectum. This is anterior resection of the rectum. This is for upper third tumor, while lower third tumors less than 5 centimeters from the anal verge are usually treated by abdominoperineal AP resection of the rectum with terminal colostomy. It is permanent colostomy because there is no more safe margin left. While tumors of the middle third, it is depend. If there is area of 3 to 4 up to 5 centimeter clear of tumor, either we can use either ways. Can be usually treated by anterior resection, provided satisfactory distant clearance can be obtained. Adjuvant radiotherapy may reduce the incidence of local recurrence after AP resection of the rectum. Middle third rectal tumor can usually be treated by anterior resection, provided satisfactory distal clearance can be obtained. The operation is easier in women where the wider pelvis facilitate dissection of the tumor. It is difficult in male with narrow pelvis. And preoperative preparations of the patient with rectal carcinoma, mechanical bowel preparations and counseling and sighting of the stomas, correction of anemia and electrolyte, cross-matching of blood should be prepared, prophylactic antibiotic, deep vein thrombosis prophylactic, heparin or Clexane, and insertion of a urethral catheter. If there is no place for, especially in advanced tumor, when there is no, it is not curative tumor, we use palliative procedures. Even if secondaries are present, palliation is the best achieved when possible by excision of the primary tumors. يعني نخلي بالنا you have to resect the tumor, even if it is disseminated, and colostomy may be necessary for intestinal obstruction, but this does not relieve the bleeding, mucus discharge, and sacral pain. In completely inoperable cases, deep X-ray therapy and diathermy or laser of the tumor may give temporary relief as my cytotoxic drugs. At the end of the carcinoma of the rectum, we start with carcinoid tumor of the rectum. Carcinoid tumor, it originates from the submucosa of the rectum. The mucous membrane over it intact and sometimes appear as small black-like elevation, less common than carcinoid tumor of small intestine and greater than that of the appendix. Then carcinoid tumor of small bowel, more common than carcinoid of the rectum. Primary carcinoid tumor of the rectum are not infrequent, and it is of slow progression and usually late metastasis. Large carcinoid more than 2 centimeters, it is almost always malignant. Then نخلي بالنا إنه large carcinoid tumor of the rectum more than 2 centimeters, almost always malignant. And this tumor usually metastasizes to the bone and frequently asymptomatic, but it disseminates to the bone and frequently symptomatic, but it secretes serotonin. About 66% of patients become complaining from effect of serotonin. Serotonin, such as diarrhea, causes an increase in the bowel tone, motility, fluid secretion, and blood flow. And treatment of the carcinoid tumor by local excision is sufficient treatment. Resection of the rectum is advisable if treatment of carcinoid, it is local resection, just of the carcinoid. But indication for resection of the rectum, proctectomy, is advisable in cases of carcinoid in this situation. When the growth is more than 2.5 centimeters in diameter, where recurrence follow local excision and the growth is fixed to the perirectal tissue. In these cases, local excision is not enough. you have to do resection of the rectum. Then at the end of this lecture, which is important lecture, carcinoma of the rectum, you have to concentrate about the risk factors and pathology of the carcinoma of the rectum, metastasis and the classification of the tumor according to the Hughes classification and TNM classification, the clinical features and investigations for the tumors. Important investigations start from simple investigation because the tumor may be advanced. It is one of the causes of ascites and hepatic metastasis and jaundice, and simple investigation, and we start with even chest X-ray, abdominal ultrasound, endoluminal ultrasound, CT scan, and MRI. Also proctoscopy, sigmoidoscopy, colonoscopy, and barium enema, and you have to prepare the patient for supermajor procedures, which is either for upper third tumor, anterior resection of the tumor with primary anastomosis after preparation and non-obstructive tumors, or for tumors of distal third and lower middle third, you have to use AP resection of the rectum, abdominal perineal resection with permanent colostomy. You have to know about informations about colostomy, indications for colostomy, and complication of colostomy, and management of complications of colostomy. And bowel preparations important in carcinoma of the rectum, which include chemical and mechanical. Chemical, we use drugs for the preparation of the bowel, and mechanical to evacuate the bowel in order to prepare the bowel for surgery. إذن نكون خلصنا 2 lectures about the pancreatic disease, 2 lectures about rectal disease, and 2 lectures about anal canal and anal canal disease. Thank you very much.